I'm going to take this opportunity, the fact that we have two CEOs that are major players on their state exchanges, to ask, with open enrollment coming up next week, we're all wondering what you're expecting and what you're expecting for 2018. We know there's been a tremendous amount of uncertainty, particularly around CSRs. I was wondering, Curtis, would you like to go first and share a few thoughts on what you're expecting?
Thank you, Nancy. And I think from our perspective, this has been an issue, obviously, that we've been watching very closely for quite some time. And as we stay close to the market, and we do that through feedback that we get through our call center, we have retail stores throughout our state where we interact with those in the individual market on a regular basis, and also with our agents and brokers, which are very critical to working with these individuals. We've been working with them to kind of get an idea of what we might see with the open enrollment period. And I think as we go into that, all of the confusion, all of the things that have occurred over the last several weeks, we're expecting a slight decline as we move toward that. I don't think that should be a surprise to anyone as we move in that direction. I think one thing that we have seen that maybe has surprised us a little bit is all this confusion has bled over into some of our other customer segments, and that's principally been our senior market. So as news reports come out about increases in premium rates and our CSR is going to be funded or are they not going to be funded, I mean, we're receiving a lot of questions from our senior population who will be going through their own annual enrollment period as well, with questions about how that affects them. So we're spending a lot of time in our company, a lot of resources to outreach, not only to the individual market, but especially the senior market and others who may be going through an annual enrollment period, to communicate to them exactly what this does mean to them.
That's great. Dave?
I would say, first of all, in New York, we have a state-based exchange, which was developed by the state, which was one of their options. I think, fortunately for many of the members in New York, it has run on a fairly stable basis. However, I would echo Curtis' comment about the instability that has occurred. Our activity is already up substantially, meaning people calling in, people going into our stores asking what's going on, because there isn't a clear delineation of what the cost-sharing reductions apply to, and the average consumer doesn't understand that level of funding in those programs, so they feel that their own coverage is in jeopardy. And they're concerned not only about losing their coverage, but I think that our members feel like they've done their part. They came out of the uninsured, the ranks of the uninsured, and they made the effort to enroll in health insurance coverage, and now they don't know what its status is, and they don't know what is going to happen to that coverage, whether they're going to lose it, whether it's going to be changed, how it's going to be funded going forward. And that level of instability is, I think, it's going to cause a number of our members to drop back out of the system.
Great, great. Well, that was very interesting. We'll get back on point with the value-based payments, and I'm going to start with a question from U.S. News and World Report that was submitted ahead of time. What does the future hold for value-based payment reforms if the Affordable Care Act is repealed or overhauled in the future? Is there agreement that the shift to value-based payment is needed for cost control? Any of the panelists? Mike, you want to start? Maybe from MedPAC?
Well, as I said, I think the challenge here is much bigger than what you might think is going on in the Affordable Care Act. And frankly, the discussions around the Affordable Care Act haven't really centered on this aspect of the Affordable Care Act. I think my expectation is that there's going to be some version of alternative payment models moving forward, not because we've really figured out how to make them work perfectly or we've perfected the regulations, although there's a lot of work going on in that area, but because the alternatives are very challenging for people in a variety of ways. So I expect that many of the models that are going on aren't directly related to aspects of the Affordable Care Act, and certainly there's a lot of stuff going on in the private sector is not related to the Affordable Care Act. And I think you're increasingly seeing the private sector continue to lead in developing models. The one thing you may not have realized in listening to Curtis and Dave talk is they both developed different models that worked in their markets. And I think that level of flexibility that you see in the private sector is such that there will be a demand from the delivery system to maintain this type of momentum.
Great.
You know, one thing I might add is that a big part of the reason we haven't had a value-based healthcare model to begin with is because of 70 years of federal policy that have created incentives to go in the opposite direction. The reason we have a value-based iPhone model and a value-based car model and a value-based everything else model is because the consumers directly benefit if companies and manufacturers deliver higher value, lower cost, higher quality, more reliable products. That's not necessarily true in healthcare because all the incentives that we've put in the other direction. So really, I mean, when we talk about value, I think it's very important to understand that value at the end of the day is determined by patients. Patients should be the ones, not experts, who determine what's valuable. And the best way to ensure that patients get to participate in that conversation what value is to make sure they're controlling the healthcare dollars that are spent on their behalf.
Great. Curtis or Dave, you want to weigh in?
I mean, I would simply add, I thought Michael did a great job answering that. I think the alternative payment models or movement toward value-based care, I think it's here to stay. I think it's taken hold in the marketplace. I think we as private insurers, as we hear from our customers, I think the expectation is we will continue to move down that path. It's desperately needed. A big part of our responsibility out to our customers is to provide affordable coverage for healthcare services, and we think moving toward a more value-based system is a critical way of getting there.
Dave?
Yeah, I would agree. I think that one of our challenges in going forward with the models, even though they are, I wouldn't say they're relatively new, but I think in a lot of markets like ours, they are relatively new, is that the definition of value to a healthcare consumer is changing. And we will be challenged to make sure that the model changes with that.
Great. Here's a question from CMS. And Avik, it's right up your alley. Getting rid of pay for delay in patent laws that allow for evergreening seem to be low-hanging fruit to help lower drug prices. Why aren't we seeing any movement on these issues to help with drug pricing?
I'm actually a skeptic on the so-called pay-for-delay initiative. So for those of you who don't know what that is, basically what happens is you have a branded drug where the patent is about to expire, but nobody knows exactly when the drug will go off patent because there's 3 or 4 patents that matter, and the generic company litigates under Hatch-Waxman to try to invalidate some of those patents. And because things are going through the courts, nobody knows exactly, will the patent expire, will the drug effectively go off patent in 2022 or 2027? We don't know, and no one knows until the judge decides. And so what often happens in those cases is the branded innovator and the lead generic competitor settle. And they say, you know what, in exchange for us being able to go first and have a certain amount of exclusivity as being the exclusive competitor instead of having 10 other generics on the market, let us launch maybe not in 2022, but in 2025. So not exactly when the last patent expires, but sort of in between. And so some have criticized these, again, called these pay for delay and saying, well, what's happening here is branded companies are gaming the system to extend the life of their patents longer than they should be. I don't think that's accurate. I think what's happened in these cases is that both sides are basically shedding risk. They're kind of averaging out. So the pharma company is saying, okay, instead of going off patent in 2027, we'll effectively start having competition in 2025. And the generic company is saying, well, instead of getting to start in 2022, we're starting in 20. So both sides half win and half lose. And it's a settlement. And the reason why these settlements happen is because nobody is certain who's going to win in court. If you know you're going to win in court, if the generic company has a really strong case, they can say, no, I'm not going to settle because I think we're going to be on the market in 2022. Go to hell, Pfizer. So so that's why these settlements happen. I don't think that it's a gaming of the system. In fact, the FTC a few years ago tried to litigate because they thought it was anti-competitive. They didn't get anywhere because of the fact that these were legitimate settlements, in my view. So I think there are a lot of things that we can do to encourage competition. I think that one is more of a red herring.
Anyone else want to comment, or shall I move on? Okay. Here's a question from HRSA. Oftentimes, clinical quality measures change because the science underlying them change. How do these changes impact how we assess the quality of care and use these metrics for pay for performance? So it's talking about the underlying measures of quality and how when the science gets better, the metrics change.
So I think there's two parts to that answer. The first one is sort of the process answer is there's a general system. It actually works differently in different companies, but overall the way I would simplify it is saying measures get vetted through processes like NQF to figure out what measures they want to have and how they want to work. And then you see an enormous number of private insurers, CMS and others figure out how those measures are going to be incorporated into a range of contracts. And so I mentioned earlier that I was concerned about the administrative costs of all of this. My general sense is we have a process that is not ideal and is in many ways administratively burdensome, but it is important that we maintain some version of that process. And I think where we're going to go now is more streamlining. We are never going to be in a situation where our quality metrics capture all dimensions of quality and are updated as timely as you would like, because the simple administrative costs of being able to gather the data and implement them become overwhelming. And I think we need to begin to think through how do we take the basic current framework we have and simplify it to a meaningful and administratively efficient approach. And that's going to be a challenge. I think there's going to be other areas like patient-reported outcomes and other types of quality measures that I think we're going to go to. But I would discourage you from trying to say, we could come up with the exact best scientific evidence, and we need to get that in front of our contracts, as soon as we absolutely possibly can. There's so many ways we can complain about the quality measurement system now that I think that might be updating all the measures might be lower on my list of things we should do.
All right. I'm going to move on because we have so many questions unless somebody wants to jump in. Dave, did you want to jump in? Please.
I wanted to emphasize the mission around quality. I think there has been a debate on how quality should be measured and what it is inside of healthcare for 30 or 40 years. What you need to do in order to take positive steps forward is you have to determine your methodology and definition of quality. And that is probably not going to be identical to the next person's. But, and I agree with Michael, but that's okay. I think what we need to do, particularly in this value-based contracting process of energizing or of putting quality in that consideration, is that it needs to be directional. If we're waiting for it to be perfect, it'll never get done, and that's why it hasn't gotten done any quicker than it has. At the same time, it has to have science behind it. But if we're going to wait for some uniform definition and process to determine quality that is going to be applied in every circumstance, nothing will get done.
Great. All right, a question from the National Business Group on Health. How are the employers engaging in this discussion? Maybe Curtis?
I'll take that one. And, I talked a little bit earlier about, with the Arkansas Payment Improvement Initiative, and that we've had strong support from our employer customers, especially the large self-funded customers. And that's not happened by accident. We spent a lot of time talking about the individual market, but the group market is very, very important to us. And it's very important that as we move in this direction, we take them into account as we do that. So we made especially the episode of CARE program, we made that central to our network strategy. It became part of our network reimbursement. But before we did that, we created opportunities to visit with all of our large employers in particular. And we went out there and explained these programs to them, how they work and how it would benefit them, and got their feedback on the front end so that we could build that into our program design from the very beginning. I spend a lot of my time out with our customers, and invariably the whole issue of value-based payment comes up in those conversations. And so that's an opportunity for them to share with me as well, and we're going to continue down that path as we refine these programs going forward. We're going to continue to seek the input of our group customers.
Great. Did you want
I'll speak briefly, sort of from the perspective of Harvard and what I know more broadly. There's a subset, I would say a relatively small subset, of leading large employers. Curtis probably spends a lot of time with Walmart, for example. There's Boeing, there's Caterpillar, there's a bunch of others I think you could name that really are doing a range of innovative things, sometimes in the space of payment reform. For most employers, it's very hard for you to engage directly with the delivery system because your carrier or insurer is between you and the delivery system. So most of the employers that I'm familiar with that are doing things are focusing on aspects of benefit design because that's a much, much easier lever for an employer to pull. There are some, I think, hopeful movements forward, things like the Health Transformation Alliance, where large employers are trying to come together in ways to push the system forward. But I think by and large, it is much more difficult for employers to engage in a payment reform movement than it is to adopt novel benefit designs.
Avik, did you want to weigh in too?
Yeah, I often get asked by particularly large employers, we're the ones who, they say, we're the ones who have the most to gain from lower healthcare costs. So why doesn't Washington, why don't experts talk to us and learn from what we do to try to lower costs? And what I often respond to them when asked is, you guys have actually been the biggest drivers of healthcare inflation for the last 70 years. It's because, again, this huge tax break that we give to employer-based coverage that makes workers insensitive to the price and value of the care and coverage they're consuming, that has led to all the healthcare inflation, because Medicare was built on that system as well. And actually, yes, employers do have an incentive to keep their healthcare costs down, but they also have an incentive not to make their workers mad by tweaking too much their health benefits. Michael dealt with this a lot at Harvard, where they tried to tweak the benefits to make them more cost effective, and the faculty went absolutely nuts and complained, right? And that's maybe not the typical company because it's the Harvard faculty, but the same dynamics apply everywhere. A lot of these large employers are actually afraid to do a lot of things that all of us at this table would say would be cost effective and appropriate ways to refine your health insurance coverage. One thing that I'm excited about or intrigued by in the last couple of weeks has been President Trump's executive order, which of course has been the subject of a lot of noise and commentary. There's a piece in there about expanding the flexibility of employers to use health reimbursement accounts, which are kind of like HSAs, not exactly the same. But I think that could be a really interesting tool for putting workers and thereby patients more in charge of the healthcare dollars that are spent on their behalf. And we could see, it, depending on what statutory authority they find they have, a lot of innovation in healthcare delivery that comes out of those moves.
Great.
I'd say one thing in response to Avik. I agree with much of what Avik said about the role of employers in his related analysis. I do want to point out one thing about competition in healthcare that does relate to the role of employers in a lot of the current policy discussion. And again, as an economist, I'm a relatively free market economist. I'm relatively pro-competition in the grand scheme of things. But healthcare is not asparagus. And one of the key challenges that we face is this pooling component of healthcare that doesn't occur for many of the other consumer products that we talk about. We are pooling sicker people with healthier people, older people with younger people, and a part of that involves just managing people in different risk profiles, and part of it is systematic pooling of people that don't necessarily want to be pooled with each other. And one of the important roles that the employer-based system provides is a way of pooling that is not inherently risk-based. And the reason why healthcare has been so challenging is because if left fully on their own, where consumers have total autonomy to choose the plan that works best for them, they will do that, which again, chalk one up for economists. But on the other hand, that leaves other people in a situation where they might not have the same options they had in the past. And I don't have any great answers to how to deal with that amount of pooling or whether the ACA did too much or too little. That's a debate that I will leave for other folks. But I do think when you do an analysis of what's going on and think about these types of things in healthcare, you cannot ever get to somewhere close to the right answer if you aren't really cognizant of how the pool is held together or allowed to separate.
Great. All right, we've got a question from the American Medical Association. One way to bend the cost curve is to shift the focus of American medicine from treatment to prevention. Can a sufficient emphasis on primary prevention and preventative medicine be achieved through free market solutions? What is the best approach?
I would, with all due respect to the AMA, I would dispute the premise of the question this way. Prevention is very important for public health for all the obvious reasons. But we all got to die of something. So if we're not going to die of cancer, we're going to die of Alzheimer's. If we cure Alzheimer's, we're going to die of, falling down the stairs or something else. We're always going to die, I think, So if we're always going to die, there's always going to be some expensive care at the end of our lives. So while prevention is very important for public health, obviously if you diet and you exercise and you don't eat a lot of barbecue like I do in Austin, you're going to probably live longer, and that's good. And you won't have diabetes and all those other complications. And those are all things we should try to achieve from a public health standpoint. But we shouldn't be convinced that that's going to reduce costs. A lot of times, actually, prevention can increase costs. If every woman in America got a mammogram, the mammogram test is cost money. We'd spend a lot more money on mammograms, and we'd have some incremental benefit in terms of early detection of breast cancer. But the reason why a lot of independent boards and medical boards say, well, no, actually it's only women of a certain age or a certain risk profile that should have mammograms is because we want to make sure that the right people are getting those mammograms so we're not massively inflating the costs of running all those tests, right? So prevention is good, but prevention is not an unalloyed good. It has actually clinical risks and it has economic risks that we also have to take into account.
Great. And of course, Mike then has to also.
Well,
We've got such a great
I'll
panel here.
I'll try and be quick.
No, I love it.
I agree again with Avik. I realize I have two fitness trackers. I'm a big fan of wellness and prevention. That just says OCD. But the issue is, if you could snap your finger and make everybody healthy until they were 105 and then they died by falling down the stairs, that would be probably a better world than we have now. The problem is most of the evidence suggests that most prevention programs actually are very cost effective, and I might say add high value, but cost effective is not the same as cost saving. And oddly enough, when we promote prevention, we're often promoting primary prevention, which is giving healthy people things. And the most important type of prevention would be secondary prevention, where you are trying to find people that have chronic conditions, diabetes, and prevent exacerbations or bad things happening. And in things like the Affordable Care Act, where there's a prevention exemption for HSAs, that focuses only on the primary prevention. The world, in my opinion, would be a better place if we expanded the definition of prevention to allow secondary prevention, treatment of chronic conditions, to be treated as prevention for the purposes of HSAs and other types of things like that.
Great. Dave, this is a question for you from Todd at one of the federal agencies. Please address challenges to convince PCPs who are caring for patients and multiple payers to transform to your models. So how do you coordinate, how do you get the PCPs to do your best practices while you're a large portion of their business, you're not the only payer that they're dealing with?
Well, it's interesting. We initially thought that we would force this issue on our PCPs because we did not know if they would adopt on their own. And as you saw from the report that I gave, we're at well over 90%. So we never actually had to get to that point. So they are willingly adopting, and they are doing so for a variety of reasons. But one, they're getting better data, which allows them to be more accurate and efficient at the point of service that they historically have been frustrated with. Also, if they show improvement in the quality scores and the health scores of the patients that are attributed to them, they have the opportunity to make more money. They're actually paid, and I don't think I mentioned it, but on the for those performing at the top end of those quality scores, those PCPs, their reimbursements can go up by 10% in 2017, and we will go to 20% next year. It's a pretty significant difference. So there's, for those that are, that have looked and evaluated the program, they've been very enthusiastic about adopting it. And as I said, one of our primary competitors is a very close follower. So I think that it's going to become the standard of reimbursement in the region where it operates.
Right. Curtis, do you want to weigh in too? Certainly you faced some of the same challenges in Arkansas, although one of the ways you dealt with it obviously was with combining with Medicaid.
Yeah, we did, and you know, that was 2010, and what I talked about earlier when we started our pilot, and I think the results that we experienced were probably a little bit different then than what Dave's experienced today. Now, had we done this in the same time frame as what David and his plan have done, you know, we may have seen something a little bit different. But we think, just as we talked about earlier, local markets, local care dynamics, all those things are important. And we think that, you know, you have to be open-minded as a plan, in order to solve problems and offer up the best solutions, you've got to really adapt to your particular market. And that's really what drove us to the approach that we found. We found that there was very common perspective, very common viewpoint that we had, that we shared with other leaders in our state in healthcare delivery and also in the government programs as well. So we thought that was a great opportunity to collaborate in order to drive what we felt like was an opportunity for greater change.
Great. Mike, there's a couple questions here about MedPAC and MACRA, and maybe their soon-to-be or current comments on it. Can you address that as a former vice chair of it? Or
Well, I'm not on MedPAC now, and so I do not speak for MedPAC. And in all honesty, when I was on MedPAC, I did not speak for MedPAC. I believe that, so I'll just say very broadly and go on. MedPAC, I am sure, will look very closely at a whole range of things in MACRA and how it's working. They have been critical of aspects of the MIPS program for a bunch of reasons, I think, and we will see what they come out with in terms of the recommendations. But the easiest thing I would say about MIPS is not all the physicians are going to be above average. I say that with some confidence. And so that creates some penalty side and some winning side, and that creates a political dynamic that I think is going to be hard to really move forward over a long period of time with a MIPS-type model. And I think MedPAC will look at that extremely closely, and I will just give a shout out to what a good job they do in that analysis, and I really encourage you to read through their materials carefully, because they really are an unbiased, great source of analysis behind these issues.
Great. Here's an interesting question, and kind of relates to a conversation actually we had last night at dinner. This is from somebody at a national organization. And it's a two-part question. What are your thoughts on Amazon entering the pharma business? Also, do you expect we will see more shifting in PBM market as a result, i.e. CVS buying Aetna and Express Scripts Avik merger? Avik, you want to start? And if others want to comment.
Well, I think based on what we know about Amazon's strengths and capabilities and technological advantages, I think it's and the evidence thus far in terms of what the kind of licenses they've applied for, there's more evidence that their first step is actually going to be in the distribution side, not on the pharmacy benefit management side. So I would look for them to try to disrupt the AmerisourceBergens and the McKesson, the Cardinal Healths first. We talked about in my presentation the 16% discount. Maybe Amazon can drive that further down through some of the efficiencies they have. But I think they do also, you know, they bought Whole Foods. They now have these kind of brick and mortar facilities that they could use to build their own network of pharmacies. So I wouldn't be surprised to see them try to attack that as well. As we know, they're a big retail organization. Pharmacies are effectively retail organizations. That's another area where their strengths are. So I think they're more likely to attack it from the pharmacy side and the distribution side rather than the PBM side specifically, at first at least. That's not to dismiss it, they might go there eventually. So I think that that's what's driving Amazon's activity based on what we know publicly. I think the CVS Aetna situation is more about a lot of things going on in the PBM and insurance markets that make it, you know, in terms of United having Optum and other big insurers having other relationships with PBMs. That's more about that internal market, I think, than a response directly to Amazon. That's my sense, but others may have a different view.
Anyone else want to comment?
Yeah, in the Aetna CVS issue has not been out for very long, so we're still evaluating that. But to think about that on the surface, there are many health plans like Curtis and my own that build our own PBMs. We happen to not have done that, but there are a lot of health plans that do that, and you bring that in-house and you operate as an integrated system. Well, CVS and Aetna, as surprising as that may have sounded, is essentially ending up in the same spot. So it's just coming to the same spot from a different direction. And I believe that it's that controlling your PBM services through at-risk health plan type populations adds stability to the PBM marketplace, and I think that's what they're looking for. As far as Amazon arriving, I think I would agree with Avik that I think they will start on the distribution side, but I mean realistically, Amazon has completely transformed the consumer model in every business they've touched, and I think for us to assume that they might stop at the distribution model in healthcare, I think would be naive. I think they're very aware that the consumer model in healthcare hasn't been very good. And there's been a lot of dissatisfaction with the actual users of healthcare services. And I think, you know, it's my estimate that they have an intention to change that model.
Great. Well, with that, I think we should wrap it up. And first of all, thank you all so much for joining us today for this great discussion. I'd like to thank Senator Ron Wyden for sponsoring our event. And I'd also like to thank my terrific team, Catherine Santora, Katie McDonald, Carolyn Myers, Kate Ellis, Kirsten Wade. You guys did a great job in helping out on this event. So let's give a final round of applause for our great panelists.